Good morning, everyone. It's great to see a large crowd. Always great to see students here as we kick off the third Willcoxon Innovation and Health Sciences Summit. Thank you for taking the time to be here. I know we're going to have a great program and you'll enjoy the day. I'm Dean Van Galen, President of Missouri Southern State University. For our university, this is a very important event. It aligns very well with our focus on health and life science. You'll learn later this morning about the Roy Blunt Health Science Innovation Center. But today is also about bringing ideas and innovations to light here in Joplin, Missouri. And we're grateful for our speakers who've joined us today. And I do want to also especially thank why this is possible, and that is the generosity of the Willcoxon family. Dot Willcoxon is here this morning. Dot, would you please stand so we can give you a round of applause? Thank you. Now I'm delighted to introduce our MC for today's event, Vicki Meisler. Vicki currently serves as the Chief Executive Officer of Ozark Center here in Joplin. A proud Missouri Southern graduate and nationally certified psychologist, Vicki has been with the Ozark Center since 1984. Vicki is an active member of the Missouri Coalition of Community Mental Health Centers and has had the opportunity to be actively involved in advancing health care at both the state and national levels. Beyond her work with Ozark Center, Vicki is a community leader, serving on the boards of Aspire Scholarship, Jasper County CASA, and numerous boards here at Missouri Southern, including the Missouri Southern Foundation as its current vice president. Vicki, thank you for serving as MC today. Please welcome Vicki Meisler.
Thank you, Dr. Van Galen. I hope there's no math students out there. 1984 was a long time ago. Please do not calculate how old I am. How many people do you think we have here today or registered today? Drum roll, please. We have hit the 500 mark, which is phenomenal for this event. I think last year we had about 370, so this is a really great turnout, and you're going to hear some really great speakers. So I'm honored to serve as the MC again for this event. The Willcoxons are special to me, and I am pleased and proud to be here. We've got an incredible lineup of distinguished speakers, and I'm going to be introducing each one of them to you as we go along. But first, a little business. We're going to do things a little bit different today. So we're going to have the opportunity for you to interact with the speakers through technology. This is a code we'd like for you to scan, and we'd like for you to do that during the presentations. This code will change by the speaker. So if you'll scan this code or go to slido.com and enter that number, you can ask questions of the speaker. You can also upvote or like other people's questions, and it will tally those votes and move those questions to the top of the line so that they get answered first. So without further ado, our keynote speaker today, Dr. Mary Joy Garcia-Dia, is the Program Director for Nursing Informatics at New York Presbyterian Hospital, where she leads enterprise-wide digital innovation within the Institute of Nursing Excellence and Innovation. Her experience spans clinical practice, health information technology, and executive leadership roles across major hospital systems, including Mount Sinai Health System, Hospitals for Special Surgery, Bellevue Hospital Center, and Columbia University's Faculty Practice Organization. Her national leadership includes participation in the AARP Public Policy Institute's CARE Act Roundtable and previous service on the National Advisory Council in research for Asian American, Native Hawaiian, and Pacific Islander health. She has advanced minority health equity through initiatives such as patient-centered outcomes research and All of Us. Dr. Garcia-Dia is an adjunct associate professor and course developer for the Nursing Informatics MSN program at City University of New York School of Professional Studies. She also serves as an adjunct assistant professor at the Francis Payne Bolton School of Nursing at Case Western Reserve University and as an adjunct faculty and clinical preceptor at New York University's Rory Myers College of Nursing. She earned her bachelor's degree in nursing from the University of St. LaSalle College of Nursing, a master's degree in nursing informatics from New York University, and a doctor of nursing practice from Case Western Reserve University, where she received the Director's Award for Outstanding DNP Graduate. She completed the Minority Nurse Leadership Program at Rutgers University College of Nursing and is a graduate of the Cold Iron Senior Nurse Executive Fellowship at Case Western Reserve University, where her scholarly project focused on ethical, international nurse recruitment and global labor migration. Please join me in giving Dr. Garcia-Dia a warm MSSU welcome.
Good morning, everyone. Are there any nurses in the house? Woohoo! There you go. So, I would really want to thank, I know Dr. Lisa Beals is not here, but I would like to thank her together with Melinda Brown and also Dean Lemons and Dr. Van Galen for inviting me, and of course the Willcoxon family for extending the invitation for me to be your keynote speaker. Today, I want to frame our conversation around a single idea. Innovation is not about technology alone. It's about how care evolves. From a nursing informatics perspective, I've had the privilege of witnessing healthcare's transformation across decades. And today, I want to explore how technology reshape what it means to care and how nurses must lead that evolution. So raise your hand if you ever worried about making a clinical error. Yeah, a lot of us worry about that. But I want you to imagine something with me. It's 2 o'clock in the morning, the lights are dim, monitors are beeping in the background, and you are a nurse on the hospital floor. You're caring for more patients that you could safely have. You flip through your handwritten notes, searching for most recent orders for your patient. The handwriting is unclear, and you pause, because you know one small mistake can change a life. That was healthcare when I began practicing my career. No electronic records, no decision support, and sometimes luck. Now fast forward to today. A nurse may receive an AI alert in the background even before the deterioration of the patient's symptoms appear. Vital signs can stream automatically from the electronic health record, and patients can be monitored from their home. From bedside-only care to care everywhere. Care has evolved, but accountability has deepened. And I want to challenge yourselves to see yourselves not just as healthcare professionals, but as architects of the future of care. I have no financial relationship or conflicts of interest to declare. What I offer today is my role as a nurse and a nursing informatics specialist who has lived through and lead this transformation. Today, I hope to accomplish 3 things. First, I would like to explore the expanding role of nursing informatics in improving patient outcomes. Second, describe how emerging digital and AI technology are influencing clinical practice. And third, examine how innovation affects our workflow, safety, and care delivery. Before we talk about the future, I want to share where my journey began. I grew up in the Philippines. My father was in the Navy. My mother is an educator. But the person who inspired me the most was my aunt. She is a nurse. When I was 14, I watched her assist a woman in labor. I saw pain, uncertainty, frustration, and extreme tiredness, and then relief and joy when the baby was born. That moment made something profound for myself. Nurses are present during the most vulnerable moments of human life. That truth has guided my career. So let me ask you, how many of you have ever seen a paper chart? Raise your hand. There's still a lot in the audience that saw the paper chart. I'm glad. Now, how many of you are trained entirely using an electronic health record? Yep, several of you are doing that as well. The generational difference represents one of the fastest transformations in healthcare delivery. When I started, everything was handwritten. As many of you have raised your hand, you experienced the same thing. Safety relied on memory, vigilance, and endurance. Today, documentation is digital, integrated, and increasingly intelligent. Healthcare has always evolved, but never at this speed. That evolution is happening faster than ever before. So if you want to turn to someone next to you, what's one thing that technology has made easier and one thing that's made it harder? Because I'm sure many of you have certain pain points when you're using your electronic health record. But I'm sure that when you're talking to Alexa, it is fun to ask, what's the weather today? And I think Melinda was saying, give me a playlist of what's going to be fun in a conference. So today, let's look at what the nursing workforce looks like. There are over 30 million nurses worldwide, caring for 8.3 billion people. In the US, approximately 5 million, and there are 342 million Americans that we need to care for. And here in the state of Missouri, 74,000 registered nurses care for 6 million people. And when I was talking yesterday with many of your leaders, it is just right that we talk about how do we take care when there is an uneven distribution of nurses comparing urban and rural communities. The demand continues to grow, and we need more nurses. So how do we provide safe, equitable care with limited capacity? The answer lies in the intersection of people, process, and technology through evolution and innovation. Over my career, I've learned 2 essential lessons. The first is this: technology does not replace compassion. It expands the reach of compassion. When designed well, technology allows nurses to care for more people, more safely, and more effectively. The lesson comes from this Filipino proverb that has guided me throughout my career, and I'll speak it in my language. Ang hindi marunong lumingon sa pinanggalingan ay hindi makakarating sa patutunguhan, which translates to one who does not look back to where they came from will never reach their destination. For nursing and clinical leaders, this is not about nostalgia. It's about practice and purpose. As we introduce new technologies, workflows, and innovations, we must remember the foundation of our profession: caring, advocacy, and human connection. Our predecessors taught us that efficiency can never replace presence, and automation can never replace judgment. Innovation must never disconnect us from our values. When we honor the wisdom of nursing practice, we design safer systems. When we remember who we serve, we lead more responsively. Technology must remain grounded in humility, history, and humanity. And when we honor where we came from, we innovate more wisely. And when we stay rooted in what values matters, progress doesn't just move forward, it moves us towards the right direction. So when I was recruited to the United States in 1988, during the heights of the AIDS epidemic, hospitals across the country were experiencing severe nursing shortage. In this slide, people watch as almost 1,500 quilt patterns or panels bearing the name of New York area residents who died of AIDS are unfolded on the Great Lawn in New York Central Park in 1988. This reminds us what happened during the COVID-19 pandemic, when nurses' shoes, white shoes, were also displayed in Washington, D.C. During that time, in 1988, I served as a charge nurse for 36 patients with minimal support. The workload was overwhelming, but it forced me to think differently about care delivery. Out of necessity, I lead and changed our staffing model. We transitioned from functional nursing to team-based care, assigning patients by acuity rather than by tasks. Within 6 months, staff's morale improved, sick calls decreased, and collaboration strengthened between physicians and nurses. I remember Dr. Steve Mackey walking down the hall and telling me, "Wow, this unit has changed from worse to wonderful." That experience taught me an important leadership lesson. Innovation does not always begin with technology. It often begins with rethinking systems. So in 1992, I transitioned to the medical intensive care unit. And something remarkable happened because our ICU became the beta site for electronic documentation. For the first time, we began documenting our admission assessment. We learned how to use the computer. Medication administrations were automatically captured. The intake and output, where we document how much the patient orally takes, was automatically calculated by the computer. And we don't have to worry about what's the 24-hour intake because it's automatically displayed. Vital signs and cardiac monitoring began integrating into electronic systems. Instead of manually entering every vital signs every 15 minutes using pen and paper, with just a single click, all the information from the monitor automatically populates, and it allows our pulmonologists to track and trend the data. Of course, many nurses were skeptical. Workflows changed, the learning was very steep. But over time, we realized technology did not diminish nursing. It revealed its complexity. Electronic systems improved visibility, communication, and patient safety. In 2000, To Err is Human released a report by the Institute of Medicine that changed healthcare forever. The report revealed that over 98,000 Americans died annually from preventable medical errors, more than from motor vehicle accidents, breast cancer, or AIDS. Can you imagine? If you were practicing at that time, that's a shocking report. The message was clear. Errors were not simply individual failures. They were often system failures. Healthcare errors are really the result of bad people. I want our nurses to understand that and to remember that. They are often the result of poorly designed systems. Errors are not personal failures, they are system failures awaiting to be redesigned. One ICU experience that profoundly shaped how I think about safety happened when I was caring for a post-operative patient receiving continuous IV sedation. During my assessment, I noticed that the patient was becoming agitated. I took the patient's arterial blood gas, and it showed that the patient is hypoxemic. I referred the patient to the resident, who ordered morphine to sedate the patient. I went on my break, but prior to that, I endorsed it to the nurse covering me. When I came back, the patient was being resuscitated. The root cause analysis revealed multiple system failures occurring simultaneously. There were training gaps, communication failures between the resident and the anesthesiologist. Alarm was beeping, but people failed to respond to it. And there were staffing shortages because I floated from the medical ICU to the surgical ICU. It was a textbook example of the Swiss cheese model of error, where no single mistake causes harm, but small gaps align across a system that can lead to an error. That moment taught me this. Even the most dedicated clinicians cannot outperform fragile systems. Excellence at the bedside is not enough if the system itself will fail us. That is why innovation cannot focus only on individuals. It must focus on building safer systems, systems that anticipate human limitations, support clinical judgment, and protect patient conditions when they are far from ideal. These experiences lead me to my specialty today, nursing informatics, which is the integration of nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice. This data approach to patient care enhances the ethical experience for healthcare providers and patients. I became the systems manager for an electronic fetal monitoring platform. We implemented real-time monitoring of maternal and fetal status. It keeps track of the heart rate of the baby. At the same time, it also monitors the contraction of the mom. So this way, the clinical nurses or physicians can double-check if the mom and the baby is in distress and apply appropriate measures and escalations. When I think about that, it is serendipitous that the first system that I implemented connected to why I became a nurse. From a bystander watching a woman in labor when I was 14 to proactively ensuring safe maternal care when I switched to information technology. Eventually, I helped interdisciplinary teams implementing enterprise electronic health records. These projects required collaboration among nurses, physicians, pharmacists, respiratory therapists, systems analysts, and integration specialists. It's a lot of people that have to come together to design an electronic health record. We conducted usability testing, site visits, and workflow validation. One of the biggest lessons I learned is that implementation is never about the software. They require workflow redesign, governance, training, and interdisciplinary collaboration. The 2009 American Recovery and Reinvestment Act aimed to modernize healthcare and enhance information privacy and stimulate the economy. That was at the time where I transitioned and was heavily involved in implementing electronic health records in physician practice at Columbia University. Digitization was not about replacing paper. It was about transparency, safety, and data-driven decisions. It's shown a lot of practice because we need to make sure that we are meeting core clinical outcomes in order to meet the meaningful use of the electronic health record. From paper to digital, from task-based systems to intelligent and predictive platforms, we are witnessing the greatest reinvention of healthcare in modern history. And you are part of the history because if by raise of hands, how many of you have access to your own patient portal or your own electronic health record? I see several hands raised, but I think we can do more. So now, how many of you have more than one cell phone in your hands? There you go. A lot of people do. I have three. I have my work phone, my personal phone, and my international mobile phone. And mobile technology really expanded care behind hospital walls. Today's healthcare is best described as technology-enabled, with consumers driving the changes, while clinicians continue to incorporate new technological solutions into their practice and daily lives. Imagine that 59% of all US adults, including older population, owns a portable device or go to the internet to access information. The use and adoption of mobile technology has exponentially increased in healthcare. I know Vicky said about my doctorate, and I did a study in the Philippines as part of my dissertation to understand what's the impact of using text messaging. We studied whether text reminders could improve childhood immunization adherence. We saw how simple SMS reminders can improve childhood immunization rates. But the study also revealed challenges: limited bandwidth, network connectivity, and of course, technology access disparities. We must understand that innovation must consider equity, access, and context. As we continue to leverage our mobile technology and our smartphones, we have seen the rise of barcode medication scanning. By scanning barcodes on medication packaging and patient wristbands, healthcare providers can confirm that the correct medication is given to the right patient in the right dose and at the right time. The technology helps prevent medication mix-up and improves accuracy, especially when we're giving medications to our patients. However, I've experienced that when implementing this type of projects, there's always gonna be resistance to change. But one day, one nurse actually approached me and she said, I was trying to scan the patient's wristband and it gave me an error. Then that made me realize that although I thought the computer was slowing me down, now I know it's protecting my patients. Sometimes innovation is a quiet safeguard working in the background. Of course, the successful implementation of barcode scanning medication administration also depends on several factors, including the availability of well-designed systems, staff training, and adherence to best practices. While scanners can effectively reduce errors, they are not infallible, and it should be complemented with safety measures. Their effectiveness is dependent upon the facility's dedication to proper implementation and ongoing quality control. Our job as nursing informaticists is to support quality, compliance, and data trending. This is an example of one of the dashboards that we created to monitor compliance in meeting the Leapfrog's initiative of 95% barcode medication administration. This report is important, especially for the patient care directors who are monitoring their units. Also, executive leaders can easily identify which campus, which site, and which unit are meeting the metrics by a simple color coding. So you could easily check in any campus to make sure that we are hitting the marks of 95% compliance. And of course, we expanded the utilization of our smartphone as dictation tools. We experimented this using our smartphone devices in the medical surgical unit. And we compared the adoption with our emergency department nurses. And as you can see here, I'm not sure if you could read clearly from your side, but AI-enabled dictation has enabled nurses to be efficient and effective. In fact, one of the ED nurses said that it helped her with her triage because she's able to talk to the patient, and when she comes back, all she needs to do is verify the notes that was captured when she was dictating through her cell phone. It improves workflow, time management, and inclusion. One of the nurses also said that through time, it was able to understand her accents, which is great. When technology adapts to clinician, adoption follows. And of course, as we continue to accelerate our digital health, we also open opportunities for us to explore remote patient monitoring in the emergency department. Through remote patient monitoring, or RPM, clinicians are able to detect deteriorations. We're able to follow up newly diagnosed hypertensive and diabetic patients discharged from the hospital. Patients are provided with iPads so they could check their own blood pressure, their blood sugar, and respond to questions. So this way, someone that's monitoring the patient virtually in a remote location is able to prioritize which patients need referral and escalation to their provider. Healthcare is shifting from reactive care to proactive and predictive models. And of course, with the proliferation of data and the ubiquitous presence of the Internet of Things coming from different sources, from our watches, from Alexa, of course, who's listening, AI is the next major transformation. I shared with you before, when I transitioned in the ICU way back in 1992, how we're able to collect data electronically. Fast forward, more data is being captured from various devices, as you can see here on the screen. Imagine nurses document 600 to 800 data points in a 12-hour shift. And that's just a shift. You multiply that by day, and you multiply that by months. Data scientists, informaticists, clinicians have the best opportunity to leverage data. What if we can predict someone who's going to fall? And I think Dr. Du will touch on that point. There is a potential for AI to be our cognitive partner, so we can focus more on what matters most and use our clinical judgment and human connection. Soon, we can imagine that technology will fade in the background. There's going to be voice documentation, ambient monitoring, and smart patient rooms. And I'm so excited what could be developed here in your school in terms of making that simulation lab transform into a smart room. AI does not replace judgment. It exposes where judgment matters most. However, we also need to understand that sometimes AI may not perform well. Models must be validated, monitored, and governed. Clinical oversight is essential because patient safety depends on it. For example, in this study looking at the sepsis model, there was a cohort of over 27,000 patients that went into hospitalization, undergoing around 38,000 hospitalizations, and sepsis occurred in 7% of that hospitalization. The study suggests that the sepsis model poorly predicts sepsis. Its widespread adoption, despite poor performance, raises a fundamental concern about sepsis management at the national level. So if you think about it, would you trust an AI system to make a clinical decision without human oversight? And that's exactly what we need to do when we're partnering with our systems engineers in trying to incorporate AI into our workflow. But also, imagine if we can predict a patient from falling. So this is, again, another model. It's called the false predictive model, which is built within the electronic medical record. Using real-time data like patient's age, diagnosis, medications, lab results, nursing notes, and fall history, the model continuously generates a dynamic score for each inpatient. As the patient condition changes, the fall risk score also changes and adapts. Unlike traditional tools such as our Morse false code or Hendrick 2 scale, this model isn't static. It can update automatically and pull a wider range of data and fits seamlessly into the nurse's workflow. We have tested this model and we're still investigating how effective it is in trying to prevent falls in one of our sites. But for nurses, this means earlier, more targeted intervention, better use of resources, and less alarm fatigue. Importantly, it doesn't replace nursing judgment. It strengthens it. The bottom line is, if we combine AI with clinical expertise, we can definitely create a safer care environment for every patient, every shift. In 2022, one of the most exciting implementation that I did in New York Presbyterian is to introduce virtual nursing. It started with one simple question: how can we give our bedside nurses more time for meaningful patient care and commit to sit with our patients? Virtual nurses stepped in to handle admissions like assessment, medication reconciliation, pain reassessments, and safety screenings. Then they took on discharges, guiding patients through instructions and coordinating every detail of their transition into home. What happened next really amazed us. Within weeks, units from other hospitals were calling us and asking us, how can we get this? When can we start using virtual nursing? The model didn't just work, it ignited. So we started with 2 units in 2 hospitals, and now we have implemented it across our enterprise and have over 1,500 technology-enabled camera that can be utilized by our virtual nurses to interact with our patients. What started quietly as a pilot became one of the fast-spreading innovations in our system, proving that we had tapped into something transformational. And of course, we had to think beyond what we started with remote patient monitoring. Majority of the healthcare organizations have actually adopted this, especially during the pandemic. It became on demand, and it connected patients to care regardless of location. Another program that I implemented, of course, is following up patient readmission. So this way we can reduce readmission for 30 days. We uncovered barriers and lessons learned, and we understood that care is no longer confined to a building. It is becoming continuous, connected, and proactive. So last year, we implemented hospital at home. Virtual nurses are able to support bedside teams, and there was an opportunity to extend care outside of the hospital. Hospital at home program allows certain patients that meet the inclusion criteria to receive care in their homes. And this is really a paradigm shift. This slide represents a pivotal moment on how we could imagine where care could be given outside of the hospital. It is not simply relocating services, it's redesigning care delivery within the patient's lived environment. And this is really something that we can imagine in terms of taking care of our hypertensive patients that might not need admissions, but can be taken care of at home. And of course, we implemented telesitting programs. But before we did that, we did an environmental scan. How effective is telesitting? What are the things that we need to focus on? And what we found out is that it could actually reduce falls and take care of patients with minimal staffing involved. The pilot was launched last year, and we celebrated our one-year anniversary on March 12. What the data shows that approximately 33 to 43% of falls can be prevented using telesitting. And this is just an example of the device that we have placed inside the patient's room. And as you can see here on the right side, one clinical observer could monitor between 14 to 16 patients simultaneously. At the same time, the software is able to detect if the patient is about to do something. And this is another way of looking at computer vision. AI-enabled computer vision improves prioritization. On this slide, the AI supports both documentation and patient interaction. This is where the AI could say something to the patient when it's about to get out of the bed. It trains the model, so this way it understands what are the geographic location in terms of the bed to the bathroom, and if the patient is about to get out of the bed, there's an automated voice that could tell the patient, please, Dr. Du, stay in your bed. I will get someone for you. And what's great about that is if the patient is not able to speak English, you could program the voice based on the patient's language. So the takeaway is that AI doesn't replace the virtual nurse or the telesitter. It makes virtual care more proactive, scalable, and precise, enhancing patient safety while preserving human judgment and ethical care. On this slide, I want us to listen and also understand how ambient technology works. I'm sure some of you are interacting with Alexa. My husband does it. He has surgeries done in the past for L3, L4. He is disabled, and sometimes he can't remember his medications. So he leverages Alexa in reminding him when to take his medications. So similarly, ambient technology works the same way, but in a better way, because it's able to recognize your voice and also able to capture key text information that could be collected and then translated into the electronic health record. So I'm just gonna play this video for everyone.
When we first started with the bridge, we went all in on family medicine, and we scaled pretty quickly. But word got out, our specialty practices were clamoring, bring this technology to us. And now we're at over 40 specialties.
My specialty is behavioral health.
My specialty is gastrointestinal oncology.
My specialty is orthopedic surgery.
The relationship with my patients is very longitudinal. I feel like it's a significant honor to be able to have this intimate relationship with them where they're sharing their most vulnerable parts of themselves. So I love that I get to see my patients sometimes for years and really get to know them. I started using a bridge when it was the general note meant for, kind of primary care. It was helpful, but when they brought the specialty note and the behavioral health specific note, it has become extremely helpful.
So the first time I noticed utilizing the orthopedic specific note, it was very dramatic, the change from general language to very orthopedic specific language, almost sounding like it was written by an orthopedic surgeon.
A bridge has become more facile, and the terminology that's used at creating the documentation that's most suitable to our specialist practice.
The ability to glean information that's very concise is improved in a really dramatic way.
So I've been very, very happy with the changes over time.
What really excites me about our future in partnership with the Bridge is that we're working on the technologies of tomorrow right now. We didn't buy a product, we bought a future. And I think that in the years to come, the work that we will do together as partners is going to be very impactful to each patient whose lives we touch.
That's a very powerful message that he said. We didn't just buy something, but we are buying something for the future. And during this encounter, how AI works is that it uses natural language processing to capture key clinical details like symptoms, diagnosis, and care plans. It then drops the note into the provider's own voice, tailored to the clinical setting, as you can see, behavioral health, orthopedics, and it integrates it directly to the electronic health record. So I'm sure many of you have been talking to your own providers, and you can see how people are simply typing the keyboard, not looking at you, right? So this is really a game changer when we're talking about ambient technology. Now I'm gonna play another video for everyone, and really looking at it from what can technology do for our nurses?
Here at Mayo Clinic across the Department of Nursing, we are excited to roll out Nurse Virtual Assistant, or NVA. It's a new generative AI tool embedded within our very own Mayo Clinic electronic health record. Nurse Virtual Assistant not only provides a nurse-patient summary in real time, but also contextualize practice links to evidence-based practice resources like policies and procedures, IV administration guidelines at the point of care and at time of need.
Everything's in one place. So I can pull up the nursing virtual assistant, AI generator will develop a patient summary about my patient, and I could see everything right there between the medications the patient's received, why the patient's in the hospital, what's changed over the last 24 hours. Having that all in one place is just a huge help.
Nurses have been involved through ideation of this as a new tool that would be beneficial to them in their workplace, through design, through implementation, and through testing and validating that the tool is working for them within the practice. Custom designed by nurses for nurses. They have really been pioneers rather than passengers in developing this tool and bringing this to life within their practice.
We have access to some powerful tools like AI now, and just integrating that into the healthcare is important for our future, I think, to better the quality of the healthcare that we deliver.
Nurse Virtual Assistant doesn't replace the critical thinking of our licensed nursing staff, but rather amplifies that critical thinking and compassionate care that only nurses can provide.
So we do hope that by localizing these resources at their fingertips at the point of care, and by embedding it within the workflows, that this will relieve that cognitive burden for them.
We really see that Nurse Virtual Assistant can impact our profession of nursing beyond our Mayo Clinic walls and truly translate into any organization.
What do our nurses think about that? Yes. Nurses are not reacting to AI, we are leading its adoption. So let's bring this innovation to life through something familiar. I've came across this application. It is a patient portal. And I know some of you have said that you have your own patient portal, right? Which is a secure digital gateway that gives you real-time information and access to your own health information like your labs, medications, vital summaries, and you can directly communicate with your care team through email. So it really transforms how you become a passive recipient of care, being an active participation in your care. So let's take it a step forward. How can this AI-powered solution like CaliCare works? It is actually designed to support elder care through something simple and yet powerful, a voice. It makes wellness calls to older adults, no app, no setup for technical setup, but just conversation. And through this interaction, it tracks medication adherence, monitors the overall well-being, and even analyzes the vocal patterns to detect any signs of cognitive, emotional, or physical decline. But what makes this transformational is the connection. CaliCare shares meaningful updates with families, caregivers, and the care team. Everyone is being brought together to have a shared understanding of what's going on with the patient. Why this matters is because there are over 15 million seniors in the US that lives alone, and 53 million caregivers that are often stretched beyond capacity. So potentially, this is where AI could probably support not just care, but also well-being, extending that presence and relationship, and ensuring that patients are not felt unseen. But as we embrace AI, we must also confront a critical truth. Innovation without ethics can cause harm. AI will not replace clinicians, we keep on hearing that, but clinicians who understand AI will transform healthcare. We've already seen that happening, that when balance is missing, error could occur. In one population, like for example, our African American population, some algorithms can cause underestimating their own health, leading to inequities. We've also seen direct patient safety risks. I mentioned the sepsis model, but what's more concerning is the consumer health AI. There have been reported cases where conversational AI systems failed to appropriately respond to individuals expressing emotional distress or suicidal ideation. In some instances, reinforcing harmful thoughts and then escalating to crisis support. These failures highlight the danger of deploying AI without robust safeguards, clinical oversight, and escalation pathways. This is why ethical AI is not optional. It is foundational. We must ask, is the data representative of the entire population? Is the model validated in real settings? Is there human oversight? And who is accountable if AI fails? Digital transformation is not slowing down. AI-assisted workflows such as ambient technology, predictive analytics, these are already shaping care. So the question is no longer if innovation will change healthcare, it's how you will lead it. Because the responsibility is clear. What we must build not only advance care, but protect life. The greatest risk is not artificial intelligence, it is unexamined intelligence. So as I reflect back on how I started my career, I want you to also take a few seconds to think about one moment in your training or practice where a system failed you, or it also failed the patient. Each wave of innovation in healthcare has done one thing consistently. It has expanded the reach of clinicians, not by replacing us, but by amplifying our expertise. When I transitioned into the ICU, I realized something profound. It did not threaten nursing, but rather it reveals the depth of nursing. When electronic medical records replaced paper, it was not about digitization. It's about visibility, communication, safety, and data-driven decision-making. Now let's ask ourselves, if we have the power to redesign that system, what would you change? Would we rather go back to paper? Would we continue to rely on AI? How do we support our healthcare system? Because every one of these innovations change how we practice. For those who have lived through this evolution, we have led it and we will continuously rewrite it. Every innovation from AHR to AI has expanded our reach. As we step into the leadership role and lead technology, our role as nurse leaders is to ensure that AI is not implemented to clinicians, but with clinicians. That starts with aligning our tools to real clinical workflows so technology can support care, not disrupt it. We must also take an active seat in the table in the governance and selection of vendors, specifically for AI, asking the hard questions about safety, bias, transparency, and outcomes. Because what gets built will shape how care will be delivered. Equally important is our workforce, championing education, building AI literacy, and ensuring our teams feel confident, not threatened by these tools. And we cannot do this in silos. Across organizations, nurse leaders must collaborate, sharing best practices, lessons learned, and even failures. So collectively, we could push for smarter system design. And that's exactly what we have been doing across the nation. We have partnered with Stanford University, Duke University, and quarterly, we share best practices on how are we utilizing mobile technology. Presentations are exchanged, so this way we can help each other to move technology forward. So if leadership sets the direction, the next question is how do we activate it? This is where institutions like Missouri Southern State University play a critical role in terms of investing in AI literacy, not just teaching students how to use tools, but how to question them, building curricula that strengthen critical thinking, ethics, and data awareness. Second, we have to be a champion for informatics competencies, ensuring that every clinicians, our nurse graduates, are not only clinically competent, but digitally confident. And third, lead technology locally. Pilot innovations in your simulation labs, and you're doing that already. You can experiment with virtual care. And of course, fourth, cross-sector collaboration, partnering with health systems, industry, and communities across Missouri to bring real-world innovation into the classroom. But as we do this, we must anchor everything in the 5 rights of AI: the right data, the right model, right context, right user, and right governance. Because innovation without guardrail is a risk, but innovation with purpose is transformation. And that transformation, I can tell, can really start here at MSSU. So if you remember one slide, remember this, when we talk about the evolution of care, we are really telling the story of how healthcare has continuously adapted to meet people where they are. We began with paper charts, which is static, siloed, and reactive. Care was documented after the fact. Then came along the digital systems and the internet. It introduced a new dynamic. Patients became informed, engaged, and empowered, participating in their own care. And today, we are witnessing the era of intelligent care, driven by data, predictive analytics, and artificial intelligence. We are no longer reacting to illness, we are anticipating risks, personalizing interventions, and redefining outcomes and being connected through our mobile devices. And this is really the shift from documentation to connection to prediction. The future of care, it's not just digital. It is intelligent, proactive, and human-centered. So when we try to look at the future, and Dean Van Galen asked me this yesterday, and I did tell him I think it's going to be a mix of hybrid humans and also relying on technology. First, it's going to be continuous, of course, because care is no longer episodic. It is always on. Through real-time data and remote monitoring, we are seeing patients beyond the bedside. Every moment matters. Second, we are connected. The ecosystem is no longer fragmented. Patients, providers, data, and technology are linked, creating a more coordinated and informed care experience. And third, it's predictive. We are moving upstream. Using AI and advanced analytics, we can anticipate deterioration, intervene early, and personalize care like ever before. And of course, it's always going to be disruptive. We understand change management processes. People will always be resistant. But these innovations are not incremental. They are fundamentally reshaping roles, workflows, and even what it means to deliver care. Because the future of care is not defined by technology alone, but by the courage of nurses and leaders to lead it. So when we talk about the future of care, which is continuous, connected, predictive, disruptive, we must ground ourselves in one constant, which is trust. For more than 2 decades, the Gallup poll has consistently ranked nurses as the most trusted profession in the United States. Not once, but year after year. That level of trust is not given, it is earned. And after decades in healthcare, through paper charts, electronic records, and now artificial intelligence, I've come to realize something profound. Technology will change, systems will evolve, but the public's confidence in nursing endures. Why? Because we built on something no algorithm can replicate: human connection, clinical judgment, and the quiet, unwavering commitment to care. That trust is our greatest asset and our greatest responsibility as we lead healthcare into the future. So as we look beyond what could happen after this conference, I want to return to the moment that began my journey when I was 14 years old, watching my aunt care for a woman in labor. I watched a nurse bring life into the world. What I witnessed that day was not technology. It was compassion, presence, human connection. The heart of healthcare will remain the same. Patients will need someone who listens, someone who advocates, someone who cares. And today, you stand at something that is just as powerful, not the birth of a child, but the birth of a new era of care. And the question is, whether it's going to happen, the question is, who will lead it? And I believe that leader is potentially sitting in this room. So I invite you to do your Slido and answer this question. What is one way you will engage with AI differently after today? I would be interested to see what your responses would be. So let's take a moment, make sure you scan the QR code, and let's see what that cloud poll, word cloud poll, would look like. And I know that our technology specialists behind the scene will be able to help us see that word cloud in a minute. With intention, open-mindedness, trust, use it to prevent falls effectively, use it with caution. I'm so glad that that is the most answer that we got from the world crowd, caution. Because the future of care is not something that we could wait for. It is something we build. It is not built by technology. It will be built by people who understand both innovation and humanity. And it begins especially here in Joplin, Missouri. As your logo says, explore boldly, care deeply, and make your impact globally. Thank you so much. And I figure this is a fun picture because I attended the Health Information Management System Society, and I was interacting with the robot, and it's amazing how we can train the robot to talk to us. So I felt that this was a fun way to end my presentation. And I'm open for any questions. Okay, and based on the popularity of the question, the first question is, how do we design systems that support nurses without creating over-reliance on technology, especially with constant interruptions like phones and alerts? Great question. And we all feel that there's always going to be alarm fatigue because of the constant interruption. When we implemented mobile technology in New York Presbyterian, we shift from a shared model where people could grab a phone at the start of their shift, but we know that that's going to be challenging. So we shifted from a shared model to a one-to-one model. So each nurse has their own mobile phones. And this was really with intention because we wanted to prepare for our transition to a new electronic medical record. Because the feature of that new electronic medical record is to allow people to use their smartphones and do secure messaging. And that's exactly where I think the question is coming from. How can we process all this information when we are dealing with multiple alarms and at the same time someone is trying to alert us or call us through our cell phone? And that's a very difficult process. And I think it's really revisiting how can we minimize these pain points for our nurses. We are in the process of doing that. We have a work group that would help us understand how could we minimize alert fatigue, so this way we also minimize these constant interruptions for our nurses. And this is why it's important for us to get feedback from our clinical nurses, so this way we can re-engage with our IT and also with our quality and practice committee to make sure that we minimize this kind of issues. The second one is, how can AI detect the tone of voice of the patient, when playing the role of a caregiver, for example, sarcasm. Many patients like to joke about their care. And I think Dr. Du could probably elucidate more on this, but this is where the training of the model comes into play. And I think there's still some work and development that needs to be done in terms of understanding behavior, because that's really hard in terms of training the AI model itself. So there's going to be a lot of testing that needs to happen in terms of introducing the voice or the tone. So you could probably have that sentiment analysis that the AI tool needs to be baked in when they're trying to train the model. The third one, how do we handle the problem with AI dictation misunderstanding what we say and the nurse verifying it without reading it? This is all about training, okay? What we want to emphasize, even with our clinical teams, is that you always need to verify the information before you could even save it. If you recall, when I transitioned to the ICU, it would automatically capture the data from the physiologic monitor. But sometimes that data may not be true because there could be artifacts, right? If you're putting on a pulse oximeter on a patient who's constantly moving, that information might not be accurate. And this is where clinical judgments and presence is important, because at the end of the day, it's your judgment that will really determine if that data is accurate or not. And this is what I keep on emphasizing with my graduate students in terms of the quality of data. Nurses are by nature data gatherers. We are at the center of getting all this information, not just by our own assessment, but also interacting with physicians, social workers, or respiratory therapists. But we need to ensure that the data that we're putting in, much more so now, is quality data. So you have that power to change that data and make that correction before you accept what the AI tool is telling you to do. So I think that's one thing that we need to emphasize from a training perspective. What do you believe is the greatest ethical risk concern regarding the integration of AI into healthcare? I think the biggest ethical concern is really ensuring that we are testing the model, so this way it is congruent to the protocols that we need to do for our patients. And one thing that I've read through other articles as well is, of course, the equity of the data, because it relies on sources of data, whether that's from the internet or just within your own organization. What we have done to protect from an ethical perspective is make sure that our, let's say, for example, Copilot, we're using Microsoft Copilot in terms of administrative interaction, improving how we synthesize our email communication or even synthesizing meeting minutes. What we did is make sure that it's secure, so we're not grounded in the web. It is just within our own environment, so to speak. I'm sure your IT folks are here and able to understand that. So we're not getting information from the internet and mixing it with our own data. We have that firewall that's just set to interact with our own data. So that's, I think, where the ethical concern would also come into play, because you don't want your patient information to be mixed outside of your organization and be rediscoverable in outside organizations. Is it true that when we use AI, it is harming our environment? I'm not a technical person, but what I understand is that the processing of the computer power requires a lot of cooling. So it would require gallons of water, so to speak, to make sure that the system is cooled off. So each time you're interacting with ChatGPT, that requires computer power. So I think that's where the environmental concern is coming from, because we want to make sure that it's not draining resources from under-resourced community. I am concerned how AI impact patient staffing ratios negatively, given that management may rationalize job reductions due to AI making tasks easier. And I think that's a very valid concern. We have implemented acuity staffing. So what we did was train our model in terms of understanding the acuity of our patients, whether it's a medical surgical patient or a telemetry or an intensive care unit. Because the differences on how we take care of the patient is, of course, dependent on how sick they are. So based on the training, then there is an averaging that happens, like a bell curve. So this way we could actually then identify what is considered as low acuity versus medium versus high. And based on that calculation, it allows whoever's the charge nurse to understand how can we level the staffing based on the number of staff that we have. So this way, patients are equitably distributed, and also looking at what the geographic location of these patients are. So I think when we design systems with clinicians in mind and getting their input, we would be able to address this issue. The next question is, brain scans prove that AI reduces brain activity. Can we be certain that new nurses being trained digitally, assisted by AI, have the foundation to question AI? I'm not a neuroscientist, but I think Dr. Du would be able to provide more information about that. But I do believe in terms of like the destruction that happens, right? Because it could potentially probably affect how we think. But again, it goes back to your foundational training, your clinical judgment. And remember, you're not alone. If you need help, you have someone within your care team to reach out, to communicate, to escalate, to talk through the situation. Just because we have these AI tools doesn't mean that we can't reach out to our peers, our colleagues for support. There's that human connection that we need to make sure that we are understanding. And I know, Vicky, you're looking at your time, and maybe I can take one more question. Oh, okay. So is your aunt still a nurse? Yes, she is. She's still a nurse. She finally migrated also here in the United States. She is in Hawaii. And one proud moment that I can share with you, if you recall the last picture where I graduated from nursing school, and my clinical instructor, Sister Pilar, who was involved with community health nursing, she was my role model, and the other person was my mom. I mentioned to you that my mom was an educator, but she really wanted to become a nurse. But of course, in the Philippines, traditionally, you listen to what your parents tell you to do. So when she retired at the age of 62, she went back to school and took nursing. And she didn't have to. She's already retired. But I think it's a fulfillment of what she wants to be. And we're glad that she did it. And she actually passed the board exam as well. So thank you so much for this wonderful conversation. Again, I appreciate the opportunity to be part of your conference. And I look forward to more innovations here at MSSU. Have a great day, everyone.